Thanks, Tori, for the opportunity to share a conversation with Alec Kimmelman, director of the Lauren Isaac Perlmutter Cancer Center and leader of the Department of Radiation Oncology at NYU Langone Health. Over this series of discussions, we've been hearing about NYU Langone and the things that set it apart from other major health systems. And their molecular oncology implementation is certainly a prime example. Dr. Kimmelman, thank you so much for joining me today.
Thank you for having me.
Tell me a little bit more about what molecular oncology is and how it differs from a traditional approach to cancer treatment.
So molecular oncology is a relatively new program that we've launched here. And traditionally, oncology was basically you have a biopsy of a patient's tumor, you look at it under the microscope, you assess what it is based on that, you use a bunch of clinical parameters and radiographic parameters, and then you make your treatment plan based on that. And we still do all of that. That is still an incredibly important part of cancer care, so I don't want to diminish any of that. But more recently, molecular testing has really become at the forefront as a way to determine very specific things about a patient's tumor. So sequencing the tumor to look for mutations that may be driving the tumor, that may be making the tumor more sensitive to different drugs, or perhaps the patient would be a candidate for a particular clinical trial. That's really come to the forefront. And the other technology of which our molecular oncology group is really going to harness is what's called liquid biopsies. So instead of actually having to do surgical procedures to get pieces of the tumor, you can actually just draw a tube of blood, just like you would in the clinic when you're doing a CBC or a standard blood test. And we can sequence that, and we can determine the mutational profile of the tumor. We can use it for ultra-sensitive detection of cancer. We can use it to look for the development of resistance. And what this molecular oncology program is going to do, and it takes full advantage of the integrated healthcare system that we have at NYU Langone Health, is that this is going to be available to all of our patients. It's going to be centrally organized and run. So no matter where you come in at any of our offices, you will have this available to you, and you will have the expertise of the group who will be interpreting these tests as part of the clinical care. So we typically would have tumor boards where we discuss patients' cases and come up with the best therapies. This will add molecular tumor boards where we're going to discuss these results and come up with the best plan of attack for that patient's specific tumor.
Can you go into a little bit more detail on that? I know you mentioned sequencing, but what are the tools that you use? Is the goal to really concentrate on an individual patient's biology and craft the care that way?
The method is basically looking for circulating tumor DNA in the blood, and tumors shed pieces of their DNA into the blood. The issue is that there's lots of other normal DNA in the blood, so it's basically trying to find a needle in the haystack. So the technology has gotten to the point with sequencing where we can sequence deep enough where we can detect the specific DNA that's from the tumor. That allows us to do a number of things. So firstly, it allows us to detect whether cancer is there or not. So you can imagine in cases where the patient had a surgery, for example, and they're deciding whether or not they need what's called adjuvant therapy afterwards, whether chemotherapy or radiation, based on whether they think there's a likelihood of cancer still being present at the microscopic level that we can't see on a scan. We used to just basically use clinical and radiographic parameters for that, but now we can actually say, you have high levels of circulating tumor DNA, so we think you need to have more intensive adjuvant therapy afterwards because we think there's a higher risk of it coming back. And it's quantitative, so it's not just saying there's circulating tumor DNA or not. You can actually say how much there is. And the alternative is you could tell someone who had just had a surgery that you don't have any detecting circulating tumor DNA. We think that the likelihood of your cancer coming back is lower, so we're going to put you on a de-escalation or a de-intensification trial, so you may be able to receive less intensive therapy. So that's one area that it's personalizing the therapy. The other is we have molecular targeted therapies that target mutations in certain genes that drive the cancers. KRAS is one, BRAF is another, EGFR in lung cancer is one that people have heard a lot about. And this will enable us to detect that very rapidly in the blood, both at the time of diagnosis, but also we're going to be monitoring patients with this serially. So this is going to be an important component of our monitoring of patients, so we can actually see whether or not resistance mutations are developing when the patient's on an EGFR inhibitor, for example, and we'll be able to see months before we'll see anything on the CAT scan or an MRI that the tumor has become resistant, but we'll know that the tumor has become resistant because of its genetic profile, and we can put a patient on a trial or an additional therapy that accounts for that.
What about your program makes it unique? I know we talked with Dr. Grossman last time about being part of an academic institution and teaching hospital. I'm sure that's involved, as is your involvement with the patient community. Tell me what sets NYU Langone apart.
So one of the key things that Dean Grossman has built here is what we call a fully integrated academic medical system. So we have a single medical record at every single clinic, every single hospital. So if you walk into one clinic, you don't have to worry that they don't know the medications you're on. That's all there. So that integration is actually a very key component of this. It allows us to, one, offer this service everywhere that we are, but it allows us to integrate the data from the patient. So every patient will have various imaging studies, they'll have regular pathology, they'll have the tumor sequencing, they'll have the liquid biopsies, and our investment in the IT infrastructure to be this integrated healthcare system allows us to put all of that data together to make the best informed treatment decision for a patient, but also will allow us to discover the next generation of therapies, because we'll be able to study what happens in all of these patients, and can we go back and learn from every month getting the sequencing from a patient's liquid biopsies. So it'll help the patients that are under treatment now, but it'll also really provide us with an incredible amount of data to learn for the future.
Dr. Alec Kimmelman, thank you so much for taking the time to join me today to talk about some of these programs at NYU Langone Health and some of the groundbreaking work that you're undertaking.
Well, thanks for having me. It was great speaking with you, Jesse.